So this afternoon, I'm going to present a post-hoc analysis of clinical characteristics and outcomes of patients in the Quantum R trial that was presented last year by Dr. Jorge Cortes, those patients that underwent subsequent hematopoietic stem cell transplantation. These patients are all FLT3-ITD-mutated, relapsed refractory, and as you understand, FLT3-ITD positive relapsed refractory patients with acute myeloid leukemia have very poor and dismal prognosis, and options for therapy are limited. Quizartinib is a potent and oral, very selective FLT3 inhibitor, and that was used compared to the salvage chemotherapy in the Quantum R trial. And that was presented last year by Dr. Jorge Cortes, where it was shown that the quizartinib arm had median survival of around 6.7 months compared to salvage chemotherapy, where the median survival was in the range of 4.2 months. That was statistically significant. Several patients from that trial were allowed to undergo hematopoietic stem cell transplantation according to the physician's discretion. And patients that were on the Q arm, they were also allowed to restart either continuation, maintenance, consolidation of quizartinib post-transplantation. So there are 245 patients in the quizartinib arm and 122 patients on the salvage chemotherapy arm. 78 patients from the quizartinib underwent allergenic stem cell transplantation without any additional AML therapy, compared to only 14 patients in the salvage chemotherapy arm. So the transplantation rate was much higher in the quizartinib arm, approximately 34 to 35%, compared to the salvage chemotherapy that was only 11%. So the question is why patients are getting more transplantation in the quizartinib arm. Of course, the transplantation was per physician discretion, but when I looked into the data, it seemed that the composite complete remission rate was much higher in the quizartinib arm. The duration of the CRC was longer in the quizartinib arm, and also there were very fewer deaths in the early deaths in the quizartinib arm, giving the transplant physician a chance to take the patients who achieved CRC, a longer duration of CRC, and still alive within the first 30 to 60 days, giving a window of opportunity to take them to the allogenic stem cell transplantation. Of course, there are many other variables, and post-hoc analysis does not have granular data, but it seems that's the reason why patients received more transplant in the quizartinib arm. Now, after the transplantation, patients who received transplantation, their survival was around 12 months compared to the patients that did not undergo transplantation, and the survival advantage was statistically significant. No matter how they went to the transplant, whether they went through the quizartinib arm or the salvage chemotherapy arm, as long as patients were getting transplant, they were reaping the benefit of the survival advantage. Now, interestingly, those patients who received quizartinib went into a complete remission, then underwent allogenic transplantation, and then started back on quizartinib maintenance. Their median survival was in the range of 27 months. So that's phenomenal in patients that have got not much therapy options and very poor long-term prognosis. So a paradigm is emerging in patients that have FLT3-ITD-mutated relapsed refractory AML. If we can use a strong, potent FLT3 inhibitor and put them into complete remission and take them to the transplant, and post-transplantation start back on the inhibitor, maybe that's one of the ways to overcome this very difficult to treat AML population. Now, we do not have the granular details of all the post-transplantation patients because it was a post-hoc analysis, but we are trying to reach out to CIBMTR to gather those data, and hopefully maybe next year we'll have some more data and we might be able to come back with another abstract or put that in our manuscript. The implications of my abstract would be, if we do see patients with relapsed refractory AML and FLT3-ITD mutations, we should strongly consider adding a FLT3 inhibitor, a strong, potent, selective FLT3 inhibitor, and there are several in the market, and I'm not going to compare one against the other, but put them on a FLT3 inhibitor in the induction regimen, take them to transplantation, and then as soon as the counts recover and the patients tolerate, put them on a FLT3 inhibitor as a maintenance. I think that's what the science would be in future.